I went out to Sierra Leone as this young doctor. I said to the community health worker I was with, I said, hey, why don't we just go out and do some patient education while we're out there, right? So I was like, thinking, oh, that's going to be great, already patting myself on the back. So I started talking to them. Started talking to them about macronutrients, and I was like, none of this is landing with this audience. Like they're just looking at me like, what the hell? I kind of said to the community health worker, are we saying it wrong? And she was like, you know what, doctor? Sit down, have a cup of tea. And she was like, I've got this. She got it, and I didn't.
Welcome to Medical Portraits. My name is Carl, I'm a physician, and in this podcast, I talk to inspiring doctors who have extraordinary stories to share. My guest today is Shubs Upadhyay. He's a physician driven to make a global impact, a path that led him to digital health and into podcasting. Shubs trained and worked in the UK, practiced remote medicine in Australia with the Flying Doctors, and later moved to Berlin, working for Ada Health, a digital health pioneer where he became the medical director. His career has taken him from the bedside to the global stage, always guided by one central question: how can healthcare create real impact? In this episode, we talk about his journey from clinical medicine into global and digital health, what it felt like to enter the world of technology as a doctor, and how he found his very personal way to drive change in healthcare. Cool. Thanks for taking the time to have a conversation with me. Really excited to talk to you. There are quite a few things that we have in common, Shubs. Like, we're both doctors. We both worked in digital health, both lived in Berlin. So let me just start with the last thing we have in common. You lived for a period of time in Berlin, and I'm just wondering what made you change countries and come to Berlin, and how was that experience?
Very good question. Yeah, so I was in Berlin between 2019 and 2022, I think now. Um, loved loved living in Berlin. Had a kid at the time. Our second kid was born in Berlin. It's a great city. I moved there because of work. So I was working initially. So I worked with Ada Health. I was medical director there. Initially, splitting my time working as a clinician in the UK and with in the London office of Ada Health. My wife is from France, and we kind of wanted a change. Brexit had just happened, and we were like, hey, I wonder if there's an opportunity potentially for us to move to real Europe. I had a conversation with Claire, the founder, and she was like, actually, you could have a great impact. We'd support you to move here to Berlin. And so that's what we did. So we moved back in 2019, and yeah, it was really, really great to then work with the Berlin team of Ada, like from there. It was a great experience.
Cool, yeah. I mean, especially when you get the chance to kind of work for the same company, that I assume that makes the transition a little bit easier. So you're not changing like everything at once. And knowing quite a few people who moved to Berlin from other countries, I know that it takes like a little bit of time to settle in, to find a place, to get to know
100%.
people, to get to know the language a little bit. Yeah.
It does take time to find your tribe, find your routine, find your rhythm of life, and 100% helps if you're working in a place where you get on with people and they make the extra effort and time to help you have a good transition and be your initial tribe. So for sure, that really helps.
Yeah. And you already worked at Ada at the time, so you were pretty deep in digital health, and we're going to get to that place. But first, I wonder, when was the moment, or was there even a moment in time where you realized, well, maybe directly practicing with patients isn't for me in the long run, but I want to try something else? Was there some moment that triggered your desire to try something new, or how did that come about?
Yeah, it was definitely much more nebulous than that. So I initially was doing both, right? So in terms of so I had when I finished med school, so like back in 2008, I didn't really have an inkling about digital health. I wasn't, some people who are like, hey, I've always been into coding, I've always been into, I don't know, design or da, da, da. Like, it wasn't really me. So yeah, when I finished med school back in 2008, I didn't really have an inkling about being in digital health. I actually optimized for, I want to see the world. I was able to, through when I'd done my first kind of initial intern year after med school, I had the opportunity to do a residency year in Australia. So I went with a friend. We went and worked in Australia, and part of the deal for going to work in Australia was spending 3 months in the outback. So I actually got first-hand experience of like what rural medicine looks like. You're literally in the hospital and you have the you have the pager and you answer it as like, hey, this is like the medical, surgical, gynecological, psychiatric, pediatric resident. Oh, how can I help you? Catch to
Yeah.
work with the flying doctors as well, which is a really, really great experience.
Oh,
And it was then, and then I came back and I was like, man, I'm really interested in rural medicine. My father was really involved in humanitarian work. And so through the work that he had done and people that he knew, I got some opportunities to work in Sierra Leone. And I tried to augment that also by doing a diploma in tropical medicine. And so I'd kind of had this notion of wanting to understand what it takes to serve the last mile, like underserved communities, right? And also where I was in the UK when I ended up becoming a general practitioner, a family physician, I actually was working in a part of Northwest London that had a lot of social deprivation. And so a lot of the things that I'd
mm,
learned actually working and practicing in Sierra Leone or rural Australia were actually really useful. And actually, like,
interesting.
I guess like medico-legally, you're not really allowed to do it. But the reality of it was sometimes in the UK, I was doing some of my consultations in like Hindi or Gujarati, and like having people leave like visibly relax in front of you, saying, "Oh, like someone I can like." It kind of removes this barrier that people have of like, "Oh, I can actually talk to you. I kind of trust you a bit more." That stuck with
Yeah.
me, and so that's where I was. That's the direction I was taking, and then it was through kind of um, people I knew and being in the right um, place at the right time that I ended up talking to Claire, who was also trying to understand what pre-hospital care looks like in the UK. Um, that's how I fell into digital health. So I hadn't really planned for it.
Quick break, I'd like to hear from you. I'm making medical portraits to inspire you, so I want to learn a little bit more why you care about it. What topics would you love to hear more about? What guests should I invite? What part of the podcast do you like, and what parts maybe don't you like so much? I'd love to hear your honest feedback. You don't have to spare my feelings. Just send me what's on your mind. On one more thing, I've recently been mixing English and German episodes. So is that okay for you, or would you rather just to have one language and not mix it up? Whatever your thoughts are, please share them with me. The easiest way to reach me is via email. Just send me a mail to medicalportraits@gmail.com or just reach out on Instagram. The link is in the description. Yeah, looking forward to hearing from you. Yeah. Yeah, it sounds like something that you like your general curiosity and like trying to see how other areas in the world practice medicine kind of led to this interest and to the interest of last mile health as you phrased it, and also just solving problems, it seems, right? Because like I've been to rural Australia as well. I was in Alice Springs like when I was a teenager, and I was really impressed like how remote it was, like living in Berlin. It's certainly nothing we know anything about. And I remember like getting on a bus and the bus driver saying, "So we're gonna go straight for 500 kilometers before we take our next turn. So, make yourself comfortable." And I think if you're in a area like that, you need to be innovative by default, because otherwise you're not gonna succeed in delivering medical care to everyone. So that's why I assume that the flying doctors was something born out of necessity, and maybe it's one of those problems that yeah, when you see it you think like, oh, are there other solutions? Can we do other things to improve healthcare? Very interesting.
100%. The area we were serving was like the size of England, like one, it was like, and there was only two villages in that area. And that's why that it was 2009, and that's where I got my first experience of telemedicine as well. They were doing telemedicine out there. So like just to riff off what you said, like necessity is the mother of invention, and they were already doing that stuff out there.
Yeah, and something that I didn't really expect is I would have assumed that you would have, coming back to England, you would have seen like a huge contrast. But it's interesting to see that you can actually find a lot of aspects of rural medicine in underserved communities, maybe like if that was your experience in Sierra Leone, for example, and actually apply some of the things that you learned in England. Maybe you can tell me a little bit more about that, like what were the things that you connected there?
I can give you one story So I just done my tropical medicine diploma. I went out to Sierra Leone as this like young doctor, thinking, okay, like how awesome, and it was a really great experience. And so I'm there in this clinic. It's like 35 degrees Celsius. You're in a hot, stuffy room. I'm there with a community health worker. We're taking a clinic together. And I'm seeing lots of young mothers who have young children and kind of having the same conversation with them around nutrition and various other things and like prevention type things. And there's a massive queue, and like literally, it looks like you're just doing that all day, right? And so I was like, you know what? I think we can have more impact here. I had this kind of really bright idea. I was like, hey, look, everyone's waiting in the queue. They're just doing nothing. And they're waiting to see us, and we're telling them the same thing. Like, I know. I said to the community health worker I was with, I said, hey, like, why don't we just go out every now and again in between seeing patients and then like do some like patient education while we're out there, right? So I was like, thinking, oh, that's going to be great. Already patting myself on the back. What a great idea. And so I started talking to them. Started talking to them about macronutrients and the things that they needed to do, holding up the things that we were going to give them, and talking about how it's important to have certain types of intake and a balanced nutrition for the kids. And like when I was at med school, I did some like theater and I did some like musical stuff. So I was happy. And you kind of learn to engage with the audience. I was like, none of this is landing with this audience. Like they're just looking at me like, what the hell? I was like, I kind of said to the community health worker, what's going on? Are we saying it wrong? Are we not? And she was like, you know what, doctor? Sit down, have a cup of tea. And she was like, I've got this. And she just proceeded to talk to people, and she knew their context. She knew the way they needed to hear that. And they trusted her. And she got it, and I didn't. And I think the thing that changed for me there, or that I learned and that I take away everywhere, is like, yeah, I think especially when we think about global health and things like that, it's about us coming into this situation and bringing this technology somewhere and kind of changing things or whatever, right? Unless you've lived and worked or lived and kind of walked in those shoes, um, your contribution there is different.
Yeah.
To that is different, and I think that really shaped how I approached like when I got into global digital health, and those conversations, but also my own practice. So when I was in socially deprived areas in London and I was talking to people, I kind of really tried to first listen and understand what was important to them in their context.
Yeah.
And so that contextual thing of, hey, don't just try to like copy and paste the knowledge that you just gained in a different context and think that it's going to work for people. I
Yeah.
think that was something that really shaped me in a lot of ways.
And I think it's a extremely interesting realization for medicine in general and digital health as well. Like this notion of, we learn so much academically, but the job of the primary care physician is not just to bring all this academic knowledge across, but the bigger struggle is how do you bring across that information? Like how do you present it in a way that it sticks and that it actually means something to the people that you're talking to? And like you said, context is so important and maybe something that we need to learn. And maybe when you're young and inexperienced, you think it's easy, but you realize so much of being a doctor is about communication. And I guess it's the same if you look in the medical tech field, right? So it's not just about offering a great technology to the people, but it's actually solving the right problem with that technology. And not just that, but making it easily usable, right? Because otherwise you have this great technology. It might even be the right technology for the right problem, but you have no one to apply it.
100%. And I think the sentence I take away from that, and it applies in both contexts you've just talked about, like meet people where they are, like take the time and effort and investment to understand where people are, because otherwise you won't be able to meet people where they are. So yeah.
Yeah. So you ended up working then for Ada. Can you tell me how did you find out about the company? How did you end up working there? And what was your role initially?
Yeah. So Ada were holding a workshop in the UK in London about understanding some of the problems around people presenting to urgent care. I was working in urgent care as well. Um, and also kind of the problems around people getting access to kind of urgent appointments, etc. Because Ada were looking at kind of using their symptom assessment tool to kind of help address some of this burden. And in order to kind of take the right approach, they reached out to clinicians who were, actually working to understand people's problems, particularly in the UK, because having been founded in Germany, they saw an opportunity in the UK, and that's kind of how I got involved then. And so I was initially working. So one of the things that Ada did initially was around the symptom assessment tool. They built a service to clinicians talk by text, so they could do their symptom assessment and they could talk by text to a doctor. And so my role was kind of getting this service through the regulator, and then hiring the team and doing the quality and the kind of processes that are around that service, where we would hire doctors to kind of take on the request that came in.
To interrupt, but
Yeah.
like talking by text means like literally texting the doctor
Proprietary
follow-up
kind
or...
of messaging. Yeah, they had their own proprietary messaging kind of chat service, and the idea was the doctors would be able to look at the assessment that had been done as well. So it was a really nice way to also improve the quality of the outputs as well, and kind of have that feedback loop with clinicians. So initially did that, and then just became more and more hands-on on like product development, and moving from, hey, Shubs, doctor in this company, can you like check this stuff that's about to go live, to changing people's minds around actually how do we weld together technical and clinical risks? How do they interact? How do we understand the contexts, as we just mentioned it? How do we understand the contexts, the clinical workflows that we are integrating into? How do we then identify risks? How do we then mitigate and design around these risks, right? And then how do we test those? And so my work became really around like, what does quality mean? What does good mean here? And building the team and the people and the processes that were able to kind of achieve that. And I think one of the big challenges was, how do you do that and still move fast? That was a big learning curve, because obviously initially we need to create these really good solid guardrails and frameworks, and evaluation methods, like what does good look like in this space. But then we also were a company that needed to ship fast, and we had partnerships with health systems. And so it was a big learning curve for me to work with our product leaders and work with our engineering leaders to say, how do we achieve this? How do we, where are the trade-offs? And so really thinking about clinicians as partners in understanding, learning about what's possible, where can we go fast, where do we need to slow down appropriately, and how that also fed into our regulatory certification, so 2A, Class 2A MDR certification as well. And so that was really exciting. And then kind of I then moved to kind of lead our enterprise offering as well, where we're integrating into health systems in the US, into Africa, into Europe as well. So yeah, had a kind of large range of roles. And by the time I was doing that, I had kind of already moved to Berlin by that point.
I wonder, it sounds like a little bit of two poles pulling, right? Because almost like a doctor in a professional sports setting, when the coach wants the basketball player with a knee injury to be back on the court in 2 weeks, but you as a doctor have to say, well, it takes a little bit longer for that knee to heal. So I'm wondering if that's also something that you felt like, on the one hand, we need to assure that we deliver quality and that we live up to the standards that we set for ourselves. But on the other hand, we have customers and we need to be fast and we need to ship new ideas and don't get like too distracted and lose time.
Yeah, definitely.
Yeah. And coming from medicine in general and being thrown into this new environment, how did this feel like? You know, I remember for me, this was like a completely new context. I was surrounded by people who came to me for advice for anything related to medicine, but it wasn't like a doctor-patient interaction, but something that felt slightly different. I wonder what it felt like for you when you transitioned from the clinical work to that company lifestyle.
Yeah, I think it was quite paradoxical for me. I think what was really exciting, there was this kind of inherent curiosity and everything, and thinking, okay, let's go for it. It's the art of the possible. Let's go for it, right? This kind of velocity and movement, which just was not the case in like the UK's NHS, right? You wouldn't try and get anything done. The amount of red tape, the amount of people who will actively try to block stuff changing. So that was really exciting to be part of. Um, and on the flip side, when you kind of raise something or you were like, hey, there's something here that doesn't quite make sense, the way you had to approach that was very different because if you flag something in a clinical setting, there's kind of this learned institutional behavior of like, okay, boom, we need to set off this protocol, we need to stop everything, or blah, blah, blah. And okay. Whereas kind of in this setting, you need to make your case and you're not the decision maker anymore. And what your take is just that it's a contribution as part of other things that are being weighed up. And I learned a lot on how I needed to bring people on board to a certain way of thinking or help people understand the second or third order effects of a certain risk or a safety problem, for example. And so that was a big learning curve that was different.
Interesting. And that definitely resonates with me. It does make a difference not wearing the white coat metaphorically as well, because people still in the doctor-patient relationship, you're expected to have kind of an answer on most things. Whereas, like you said, in a company, you need to state your case, you need to convince people. You don't have this, gap of knowledge in the strict sense because you just have different areas of expertise and you all need to work together to bring this to good use. And yeah, it takes much more convincing sometimes. Whereas in the hospital, where you're like, okay, I'm the most experienced physician in the room, so I'm going to make the call. It's a bit more natural, even though hierarchies maybe loosen up a little bit, but still it's different in the company, right?
And it's interesting because then if we use your analogy of the sports doctor, right? Everyone's trying to get the athlete back on the field. 7 times out of 10, the athlete shakes it off and maybe they're okay. But in the other times when their injury got worse, and because of that, they're now, instead of being out for 3 weeks, they're out for 6 months because they need surgery now because it was completely ruptured instead of a small partial tear, right? Suddenly it's like, oh, well, it's the doctor's fault. It was their call. So that's another thing that can happen.
Yeah, absolutely. Can you tell me like a little bit of the later stages of like what their initial offer of kind of making the doctor-patient communication a little bit easier turned into over time?
So initially, yeah, this period where we'd had this thing where people would be able to, additionally doing a symptom assessment, have a text conversation with the doctor and kind of help with the next stage of like, okay, what do I do with this information now, right? And then kind of Ada strategically said, okay, well, we can partner with organizations that do this well, and that's their kind of whole modus operandi. And Ada kind of then doubled down on the technology and kind of really pivoted or added to the offering of like the consumer offering, which was going like direct to consumer to, hey, how can we create value for within health systems? So ended up kind of like leading our enterprise offering, which integrated Ada as a digital front door into health systems in Europe, in the US, in Africa. And again, the kind of the use cases or the value propositions were mostly aligned. It was often trying to create value, at the same time for patients in terms of improving that seamless experience for them. For clinicians, i.e., being integrated and kind of giving them information before they see the patient, and so taking some of the history to save time, and then helping the system overall to get people to the right care at the right time, right? And so that was really kind of the strategy to create value there for our systems. And again, we learned so much from working with forward-thinking health systems who are kind of really trying to do this well. That was really, back in even 2019, 2020, there were some really forward-thinking health systems who were like, hey, how do we do this right? And, we learned a lot from working with them and integrating and creating value for them.
Yeah. I find it really impressive how companies sometimes dare to change their offering significantly, how they pivot to a new direction because they feel that they can provide more value to the users or to a new user group even. And I think from, like you said, maybe in the NHS, and that's probably no different in Germany, where things in the clinical life move much slower, and sometimes it's frustrating that things, you can't get done like new ideas as fast. On the other hand, with innovative companies, also you lose a little bit of certainty, right? You don't really know also in terms of your career where it's headed. All the titles constantly change, the teams change, everything constantly moves and nothing stands still. I wonder what your perception around that was. Was that something that you notice? Was this something that affected you in any way? And how did you feel about it?
It's a really good question. The analogy I would use is, as a company, you're kind of trying to find product market fit. And what the market wants, it's dynamic, it's not static, right? And so companies are always trying to innovate themselves into how do we evolve our offering? How do we stay relevant? How do we make sure we're offering stuff that a product and a service that people care about? And I think that's how we should be thinking about our careers. And therefore, even within Ada, I was in the same company, kind of you really need to be thinking, okay, how am I creating value here? How am I helping the company to achieve its goals? How am I upskilling myself, my mindset? How am I thinking about what I have to offer to stay relevant, to stay creating value? And again, depending on the direction the company goes as well, then that changes as well. And sometimes you're in the slipstream and you stay relevant. And sometimes it's time to get another bus. And I guess that's inevitable and happens. And so, yeah, like in terms of the culmination of the story, then, I really then, after being 7 years at Ada, moving to a kind of more comms facing role, kind of reached a time where kind of mutually we said, hey, like, I think it's time where now what I have to offer is kind of needed by other people, and Ada needs a different skill set. And so, yeah, we parted ways in January.
Yeah. I was saying earlier that there are more things that we have in common, and one of the things is that you are also podcast hosts and you've hosted at least two podcasts that I know of. Maybe you can tell me a little bit of how you got into that field, like what inspired you to start a podcast?
So the other podcast you knew about, I did this years ago when I was working as a clinician and when I just started with Ada. And I knew a lot of people who were doing interesting things with their careers. And a lot of people were burnt out with being a doctor and wanted to kind of leave or explore other opportunities. And even more so now, by the way, but even kind of then around 2016, 2017, people were thinking about this. And I was also had this opportunity with Ada, and I kind of met a lot of people who were also doing other things but staying in medicine. And so I had initially started this podcast called Two GPs in a Pod, where I was one of the GPs and I'd get another GP or family physician to be on the podcast with me. And they had something interesting that they'd done with their careers. Like one had worked in NHS England leadership. One had been the doctor for David Attenborough on like Planet Earth documentary, like that world famous Planet Earth series. And he was like 90, and she was like, it was so stressful because he was like, it was her job to keep him alive. Right. So yeah, talking like a bit, very similar to what you're doing, like talking to doctors who have something inspirational about their lives and their careers that are adjacent to the medicine that they're doing, right? And then when I had moved to Berlin, I kind of had to stop doing that because I ended up being full time at Ada and kind of wanted to really invest in being there and being present to grow there. But then one of the things that I was doing when I was at Ada with the quality framework, I had the opportunity to work with the ITU WHO. So ITU stands for the International Telecommunications Union, experts on standardizing stuff. And the WHO expertise on healthcare. And they'd come together to create this focus group, AI in healthcare. And the idea was to create benchmarking for AI in healthcare. So this is back in 2019, so pre-generative AI. And I was working with them to create the pipeline, like what does benchmarking look like in a way that the world trusts it, and so does industry, right? How do we create this? Because a lot of companies like Ada and its peers were doing studies, but then everyone would say, well, that's your study, and okay, of course you're going to come out the best in your study. Standardization organizations understand what does benchmarking look like. See things that have come out and fed into the conversation now about benchmarking generative AI and LLMs, by the way. One of the things that I was co-chaired a clinical evaluation working group that worked horizontally across all the modalities. So there was imaging modalities, machine learning, there was our symptom assessment group, there was many, many different modalities. And so I was working to kind of gather this group of experts, technical experts, clinical experts, machine learning experts, to kind of come together, like what does clinical evaluation for AI in healthcare look like? And so we kind of published some guidelines and frameworks on this. And it was there that we'd made a proactive effort to understand the work that was going on in low and middle income countries. And when I met those people and heard about the work that they were doing, I was like, it kind of took me back to the work that I'd done in Sierra Leone, right? And so that's
Yeah.
kind of what motivated, and especially when I moved to my comms role in Ada, I saw that all the comms in the industry was very EU, UK, US focused, which of course there's so much great innovation. When we talk about evaluation, when we talk about regulation, of course it's very focused and very hyper fixated on what's going on in these contexts. And whilst there's a lot to still do in low and middle income country context, there are really, really good examples of good implementation. There are really, really good examples of co-design. There are really good examples of how to create systems with people like that, create tools that are people-centered or actually have actual broader system transformation in mind. And so I set out to create that podcast because I was like, this these stories and this in perspective is just like missing from digital health. Um,
Hmm.
we talk about like health equity and the digital divide. We talk about responsible AI, but a lot of these perspectives are missing from that conversation. And so I kind of reached out to some of the people that I'd worked with in the WHO and the ITU work, and I was like, "Hey, can you be on my first podcast?" And luckily, like they said yes. And so I've now done 17 or 18 episodes, talking to people like from across all the layers of the like global digital health ecosystem. And it's really a podcast like sharing the insights of people who care about underserved communities with technology in
Hmm.
healthcare, right? And so policy, like WHO level, government level, the actual innovators and their learnings from the field. So not just successes, but things that have gone wrong and that they've learned. And so that's been really, really eye-opening. And one of the things that I've loved continuing since I've left Ada, it's been one of the things that I've really tried to kind of grow on, build an understanding.
Very cool. And having started podcast myself, I was surprised by a number of things. Like, for example, how generally people are very willing to share their story and to share their perspective. I didn't expect this openness at first, and I was really pleasantly surprised by that will to share their stories. And also, I was surprised by how many extremely interesting people you get to meet once you get the ball rolling. I'm wondering, what was your experience like? Was there anything that surprised you that you didn't expect? Having had this previous podcast experience, maybe you were already kind of aware of what this podcast life would be like.
One of the things that's so the first podcast I did, I only did 10. Read this statistic, right? I think something like 90, I don't know the exact number, so just go with me in terms of order of magnitude, but something like 90% of podcast episodes don't make it past 20 episodes, right? Um,
Yeah.
there's only like a small amount of people who get like the majority, the lion's share of the listens or engagement or whatever. And so right at the beginning, I was like, you know what? I'm just going to optimize for making these stories visible. I'm going to try to talk to as many awesome people as possible. Those are going to be my metrics that I find interesting. And I'm going to try and do 20, right? I'm going to get to the 20 and 25 and then reassess and see what I've learned rather than, hey, I'm going
Yeah.
to build this like massive podcast thing. And like, my podcast it's not like got thousands and thousands and thousands of listeners, but it has got a small group of listeners who are across different layers. So who I was aiming to reach in the global health community, digital health professionals, policymakers, but also people in the US, the UK, and Germany. And for me, that's the perspective I really wanted to open eyes and kind of change minds of like, hey, look at the big upside problems. Like, hey, we're working in Europe and the US and the UK on like relatively marginal gains, right? We're going to save doctors 2 minutes. Isn't that amazing? Yeah, there's a lot of money doing that and bringing the joy back to clinicians. I'm not taking anything away from that. But do you know where most of humanity lives and where the biggest upside problems are to solve? And like, when are we going to get that flip of that being an economic ROI? And it's going to come, I think. And so I'm really interested to take the learning back to my colleagues and my friends at Amboss and Ada and other places, hey, like look at the cool stuff that's going on here. And so I've just tried to
Yeah.
optimize for that. I think,
Yeah.
yeah, I think my big learning was like, just, you know, stay curious. You mentioned this earlier. And just let every episode be slightly better than the last one.
Yeah. Like you said, it takes time. It's a little bit of a marathon, right? So if you think this is like a quick race to the top, you'll find yourself realizing that it's not the case. If you don't do this for genuine interest and because you actually enjoy the conversations, then you're very likely going to be one of the 95% of podcasts who don't make it to 20 episodes, but rather
Yeah.
just see it as an experience, which is also fine, right? It's enough time to learn something new. But yeah, I absolutely agree with you that it needs to have this inner purpose.
100%. And I think the other thing that I changed my mindset on was, at the beginning, I mean, even now, sometimes you make a lot of effort to pour your heart into it. You do the show notes, you put things, I write sometimes my reflections on it, and you put it out there, and you're like, does anyone even care? Right. Also,
Yeah.
someone told me, look, Shubs, like you're creating this body of work that's of value to some people, right? And it's not like, oh, you put this episode out and then there's like this engagement for a week and then you forget about it. I have people who
Yeah.
kind of contact me and say, hey, that episode you did like a year ago, that was so useful. I really needed to hear that. That's like creating this like evergreen and timeless body of work that is
Yeah.
relevant and helpful for people, right?
Yeah.
Who might be going through something where you're then providing something that's useful for them.
Yeah, it's very encouraging to see it that way. And I also agree, this format offers this a bit better than shorter formats. If you look at the fast pace of media cycles in general, but more specifically social media, where a lot of things aren't made to last, right? Whereas I think podcasts have a better half-life, right? If you look at it that way, and they will be relevant to some people in 1 or 2 years from now. And
Yeah,
it's not just something to throw out to keep the conversation going, but it's actually something that people might care about years from now, which is really encouraging. I agree.
absolutely.
I'm just wondering, like, is there any guest, any topic that you talked to recently or learned about that you want to share? Anything from your podcast that might be worth tuning into?
Ooh, maybe I've got two. I mean, of course they're all good.
Naturally.
There's one that you might be interested in, just with your work at Amboss and kind of your, from an engineering and kind of creating products perspective and feedback, right? So there's this episode I did with someone called Echo Vanderwaal, and she's created both physical health infrastructure and like digital infrastructure within a very, very small kingdom called Eswatini. She talked about they would have, so they had their engineers, who their software engineers were like, would literally go onto the ward and follow the nurses and the doctors around the ward.
Hmm.
And then they would go into the corridor and they'd be like on their computers, like coding, and like, oh, we just made this change, and like
Wow.
reset it. And they're like, okay, can we like follow you doing this now?
So
Feedback
cool.
loop you could ever dream of.
Yeah.
How could we get those types of feedback loops in hospitals or clinics in Europe?
Yeah.
Can you imagine like the speed? We think that AI would speed up velocity, but if you had those types of feedback loops like really right out in the field in the world. So that was one.
Yeah.
Uh,
Super interesting.
And I think if the other one I would say is, another good episode is with Rowena Luck, who is an impact investor in Africa, called Africa Health Ventures. She makes a really, really compelling case for why it doesn't just make like some kind of like humanitarian or altruistic sense to kind of invest in Africa, or healthcare in Africa. But this is Africa's moment. We're talking about it in the context of like US aid funding has like stopped. Everyone's like, what the
Hmm.
hell do we do now? And like, a lot of people are looking to investors and from the private sector to kind of step up and say, hey, you guys know how to create economically viable organizations, right?
Yeah.
So how can you help create what's like locally needed and meeting the market where it is? And she said she made this amazing, great case for like why Africa, in terms of its population and growing, and kind of the fact that it's a digital native population, like a big percentage of the population is young. I think that was really powerful. I'd also challenged her, or had some assumptions of mine changed in that, where I was like, hey, but like, aren't investors like just interested in getting their returns? And maybe like it's philanthropy or development funding that has a long-term view. And she was like, really necessarily the case. Actually, sometimes philanthropy funding and development funding come with their own kind of rules, their 3-year funding cycles. And if you don't meet some kind of like crazy metric, but actually you did some really real good, you might still not get your funding funds. There are impact investors who are like, yeah, we've got a 10 to 12-year investment plan with you, and we are funding the things that will make you an economically viable business. And you need to be, we talked about healthcare outcomes and things like that, and they often take 10 to 12 years to actually achieve, right, the actual health outcomes that you need. And so you need to make sure you're economically and financially viable to be able to achieve those. And so she was like, hey, like, actually, the good investors, and there are different types of flavors of investors, they're not all like that, but good investors will think about it this way. And so it's not just about short-term ROI. There is this kind of longer, bigger play. And also for them, then that can scale. So that was a really powerful one for me that kind of changed my mind a little bit. Yeah.
Really cool when a conversation has this ability to look at things differently, where you actually learn something substantial that might change your view. You've been in so many different fields. I'm going to sum it up a little bit. So you work clinically, you worked in digital health, global health with the WHO, then you did podcasting. It looks like so many fields of interest, but I'm assuming that there's also kind of one common thread that holds us together. And I'm just wondering what drives you into all these different fields or into these different aspects of the same thing, which is medicine. And what would you kind of recommend, maybe younger physicians who might be interested in one of these aspects?
And it's around health equity, right? And basically I'm paraphrasing it, but the people who need healthcare the most are the ones who are least likely to get it. Right? So we're really talking about underserved communities. And when we talk about value in healthcare, for me, this is like a really, really important pillar of quality and value. How do we make sure it's prioritized? How do we make sure it's the people who are making an effort, the vendors who are making an effort to do this are rewarded? How do we make sure the system actually plans for that? And so the common thread is really, I really care about what it takes to create value, real value for people, especially underserved communities in healthcare.
Yeah.
And, if we want responsible AI, and if we want kind of really good digital health solutions, I think we need to be mindful as a society about what we're optimizing for. We are a system, we're a closed system somehow, right? And a system the outcomes we get will be a result of all the things that we're doing and the decisions that the system's making, right? One of the outcomes to be responsible AI and impact for everyone. Are we doing the right things in this system to make sure that this happens? And vendors might say, okay, well, we've got like our part of the system, like we're building, we've got these things that we need to do. And then health systems will be part of this system and say, we need to do certain things, but the vendors are doing enough. And then the vendors will say, well, health systems are not doing enough because they're not putting in their procurement, so we can't make it a business case. Or the regulators will say, well, they need to. So basically, I think we need to really think about what we want as a system, because at the moment, I feel like with the pace of everything moving forward, I think we've unconsciously made AI the goal again, instead of what system change do we want? What decisions do we need to make? And then there's like the third or fourth, how will technology serve that?
Yeah.
And I feel like we got it backwards again because everything's just so fast and we've all got FOMO that we'll miss this once in a 10 generation opportunity.
Thank you for your perspective, Shubs, and thank you so much for this conversation. I could keep this going. Yeah. Thank you so much for sharing your interesting story here.
Thank you for having me, and really happy, and we're really happy to see that you're kind of taking this time to share experiences of clinicians who are doing something and kind of inspiring the next generation of clinicians. I think that's really important.
Thank you for listening to Medical Portraits. If you enjoyed this episode and want to hear more inspiring stories from the world of medicine, make sure to subscribe to the podcast. See you in 2 weeks.